Health and Wellbeing Queensland acknowledges the Yagara and Turrbal people, the traditional custodians on the lands on which this podcast was recorded, and the traditional custodians on the lands and waters on which you are listening. We pay our respects to the Aboriginal and Torres Strait Islander elders past and present, for they hold the memories of the traditions, cultures and aspirations of Australia's First Nations people.
Young children need to experience the range of human emotions that we all experience: sadness, happiness, frustration, anger. And they need to learn those and how to manage them and build their toolkit of what responses they're going to use and how they're going to feel okay in those moments of discomfort.
Hi, I'm Dr. Sam Manger, a GP and your host of this series, The Clinician's Guide to the First 2,000 Days, brought to you by the Queensland Government through Health and Wellbeing Queensland. Prevention across the first 2,000 days offers an opportunity for healthcare professionals to support generational health improvements. But preventative health will only be successful if it is done with confidence and empathy and an evidence base. Over the course of this series, I will be talking to some of Queensland's leading experts to explore how they discuss preventative health and how to create meaningful change for the next generation. Let's get started. Today, I'm talking to Dr. Jennifer Deacon and Dr. Nicole White around all things medical in the baby and toddler years. Dr. Jennifer Deacon has been a paediatrician for almost 20 years and is currently a senior staff specialist at the Gold Coast University Hospital and the paediatric lead of the Lavender Mother-Baby Unit, a statewide maternal mental health unit. Dr. Nicole White is a GP and director of the Neighbourhood Medical Centre in Brisbane with a clinical paediatric focus. She's a GP liaison officer at Children's Health Queensland and GP representative on multiple paediatric clinical networks. Thank you for joining us so much, Jennifer and Nicole.
Hello, Sam. Thank you.
Thank you.
Nicole, let's start with you as a GP. Children present to GPs at multiple time points for routine health checks or vaccinations, say at 12, 18 months and 4 years. What are the key components of a comprehensive health check for a child, including growth assessment during the toddler years in that period? And are there any standard assessments you would complete really regardless of the reason they came in to see you?
I usually start my consultations with asking the parents what their concerns are, if they have any, with their child, and I'll address those foremost. Then I go through my standard set of things that I want to know about in terms of general health. So first of all, I'll ask about sleep. What's the sleep habits of the child? How long are they sleeping? What are the techniques used to get the child to sleep? Are they waking through the night? Are they relying on bottles or feeding through the night to help them stay asleep? Then I want to know about the diet. What's the child eating? How are they eating? Are they eating meals with the family? Are they snacking through the day? And that leads on then to physical activity, I suppose. How active is the child? Are they organised activities versus just general recreation? And how much time are they spending on screens while they are at home? Ideally, then I'd go into thinking about the development of the child and looking at their gross and fine motor development. How are they progressing with their communication, and what's their social and emotional development coming along like? And also really important, I think, to consider the parental well-being. And obviously this is a lot to cover in a standard GP appointment of 15 minutes, which is why the benefit of multiple appointments is helpful. You can build up a picture of the child, but parents can't pour from an empty cup, so it's really important to have an understanding of how parents are coping and what their situation looks like within the family. From there, I guess I go into a physical examination, and that's usually the shorter part of the consult, really. I'll always check height and weight, and I try to do that opportunistically regardless of while the child's presented to me if I can. And then a more specific targeted physical examination. If they're coming for immunisation, I'll always do a full checkup, including ears, throat, listen to their chest, listen to their heart sounds, feel their tummy, overall sort of appearance of the child. That's probably the main things that I would focus on during a child health check.
Can I add something there, Sam? I think it's always nice to start these consultations with a question of what's going well. Sometimes we get so caught up in how difficult it is to be a parent that we forget to celebrate the successes. Change happens so quickly in these years, and I think it is good to focus some of the consultation on the strengths of the child and how the family is helping them to be their best.
That's excellent. So we've got any concerns that might just be right off the bat, what's going well, what are the strength and protective factors that are present, then some of those lifestyle determinants, sleep, diet, physical activity screens, developmental milestones, and then zooming out a little bit, looking at the parental and family and sort of social context of that child, and then, as you say, the physical examination. Do you ever On the flip of what's going well, do you ever routinely assess for adverse childhood experiences? Because that's obviously a fairly important thing to identify.
I won't bring that up in every consultation, but certainly if there are concerns from a neurodevelopmental point of view or a social and emotional wellbeing point of view, then yes, I would try to gently explore those things.
When we talked about some of those significant developmental milestones that can occur from 12 months to the 5 years of child's life, that period that we're talking about today, Jennifer, how can healthcare professionals effectively monitor and assess these milestones, including supporting the parents to be aware of them, to identify any potential delays or concerns?
So the toddler years are a time of massive change, aren't they? Children go from being completely dependent to being independent. They go from only being able to communicate with crying to long sentences with meaning and lots of who, what, why questions. They go from needing to be carried to walking, running, jumping, throwing, catching, kicking, all those things that we expect our children to be very good at by the time they get to school. And so it's really important that at each time we have contact with the child, whether it's at a GP, a paediatrician, a therapist, or an emergency department, that we think about how children are going. So I think we all know that we walk at about 12 months, but we probably don't know when we're supposed to put 2 words together and what the red flag is for not putting 3 words together. And so the Queensland government has a red book, which you probably remember from when you weighed your babies, measured their head circumference with the child health nurse. But embedded within that is the ages and stages questionnaires. And they're an opportunity for any clinician to sit with a parent and ask about the normal developmental stages for that child. And then there's also another resource called the Red Flags of Development from Children's Health Queensland that says when we should really worry. And a thing that sits across this whole period is, are you concerned about the social communication of your baby? Because that not only speaks to the baby, but it speaks to the environment that they're growing up in. Because there's increasing evidence that relational health is the thing that grows babies' brains and results in the best outcome, school readiness, and then adult life for children.
If there is a concern identified, you mentioned some of those red flag components, how can we appropriately communicate our concerns to the parent without causing distress or even potential judgment?
Often the concern has been raised by someone that they trust. So a gentle way to ask the question is, has anyone else that cares about your child expressed concern about how the development's going? And that might be grandma, it might be auntie that visits occasionally, or it might be the daycare leader that expresses those concerns. And so asking who was concerned and what they were concerned about, but then that second question of, is it impacting on how things are going for you and your child? Because you can imagine that tantrums become a problem if toddlers don't communicate well, as an example. So yes, asking who was concerned, asking the parent if they're concerned, and just giving them a bit of anticipatory guidance about what you would expect over the next 3 to 6 months. And if this doesn't happen, who they can connect with, who they can seek more support from.
Excellent. So very supportive, but almost a sort of normalised approach. So this is
Absolutely
part of our routine check.
Yeah, because some babies don't walk till 18 months. And when you ask their parents, they didn't walk till 18 months either.
Yeah, so also assessing what might be normal for them as well and using those guides, whether it's the red book or the red flags, to sort of guide us to some degree. And as you say, effective referrals after that. So one of the big aspects of the child health check is obviously vaccinations, which can for some be a very simple decision. For some, it can be a really complex and loaded conversation. It's a common reason that people present and parents will present. Nicole, in Queensland, what are the recommended vaccination schedules for children? And if a parent does raise some concerns, how can we effectively address them in a respectful way?
The routine vaccine schedule is based on the National Immunisation Program, and that sees babies vaccinated at 6 weeks, 4 months, and then again at 6 months. And then from there into the toddler years, it's 12 months, 18 months, and again at 4. And occasionally there's opportunity for other vaccinations in Queensland. The state government's now funding the meningococcal vaccine, which is often given separately to the National Immunisation Program vaccines, and so that is a 3-dose schedule if children start before the age of 1 or a 2-dose schedule after 1. So in those early years there's fairly frequent visits associated with vaccination, but then there often is a bit of a gap between 18 months and 4 years of age where there's no routine need to present. In terms of vaccine reluctance, I suppose, I think it's really important to get an understanding of what the concerns are. So everybody who has concerns about vaccinating their child has a reason for that, and it's often a very firmly held concern or worry about vaccinating their children. So I think the first part is getting an understanding of what their concerns are. Where has their information come from? Is it based on their own experiences as children and what their parents believed? Is it social media? Is it family, friends, cultural beliefs? So understanding where their concerns have come from and listening without judgment to those concerns and empathising that their fear or concern is genuine and providing some validation to that, while also, I suppose, reassuring them that vaccines are safe and I say to them, I firmly believe in the process of vaccination and that we should vaccinate children, but I'd really like to have this conversation with you about the concerns that you have and see if we might be able to help you feel a bit better about the process. You know, there's a lot of misinformation on social media or a lot of information. So I ask them where their sources are and I ask them to consider taking a balanced approach. So they've consumed a lot of information about risks and negative things about vaccines. So I encourage them to consume the medical and the evidence-based information about why we should vaccinate children so that they're getting a balanced set of information on which to make their choices. I find there's a table in the Australian Immunisation Handbook that's very useful. It compares the risk of the disease that we're vaccinating against versus the risk of the vaccine. So pertussis is a prime example there. So about 1 in 125 babies under the age of 6 months who get pertussis will die. 1 in 10 children will get a mild reaction to the vaccine, and adverse events are very, very rare. So some parents really like those figures and like to know. I see my role as trying to make sure that the parents are making an informed choice. It's not necessarily my role to change their mind, but to provide them with the information they need to make an appropriate choice for their family.
Jennifer, this must be something you talk with parents quite a bit about, I imagine.
Yeah. Over the years, I think I've changed from is your child immunised to what have you decided about immunisation, and really respect parents' decisions to lead the immunisation schedule. We make recommendations. But I think the other really important thing is that we immunise against preventable childhood disease. So we've changed the outcome for so many babies across the country and prevented so many hospital admissions, so many intensive care admissions. And so sometimes something as simple as saying there is pertussis in the community. If you choose one immunisation, perhaps we could do whooping cough this year, is a gentle way to start.
Yes, it can be for some a fairly delicate and sensitive topic, and for some, as I say, not so much. But personalising it from what you're talking about, identifying those concerns, and then potentially, if not having the full schedule, but personalising the schedule to some degree, is better than nothing.
And working towards full immunisation.
Yeah, exactly, over perhaps a longer period of time, if that's the way the parent is more comfortable. You mentioned the Australian Immunisation Handbook there. Are there any other good resources? As a fellow GP, one of the things parents report to me is a little bit frustrating is that the information they were given is a bit basic and almost patronising in how basic it is. So it's safe, accept it because we told you it's safe. And they might want a bit more detail. So the table is an example of quite a bit more detail there. Have you found any resources that are a little bit more comprehensive for patients?
Not specifically, Sam. I think the handbook's probably my main go-to for educating parents. The Raising Children Network also has information about vaccinations on there.
And when parents have an immunisation, they are provided with further written information
That's right,
about the things that might go wrong after that immunisation. And I guess it would help many parents to talk about that before the immunisation happens, which we don't always get an opportunity to do.
No, we don't. You're right.
But most parents do leave an immunisation with we will watch out for in a written form.
That's right. They're generally given a handout of this is the vaccination your child's had and this is what to expect.
Stay with us. We'll be right back to continue our conversation.
Rising rates of chronic disease are one of our greatest public health challenges. 2 in 3 adults and 1 in 4 children live with overweight or obesity. We need to shift the dial. That's why Health and Wellbeing Queensland has created the Clinicians Hub. Designed for health professionals to support preventative health, Clinicians Hub is a digital ecosystem of initiatives, resources and tools, such as podcasts. It supports clinicians with referral pathways, models of care, education opportunities and more. Find out how Clinicians Hub can help you at hw.qld.gov.au/hub.
And now, back to the conversation. Now, we talked in your comprehensive healthcare check around a number of things, as you said, concerns in lifestyle development and so forth. And so let's zoom in a little bit on these lifestyle and social determinants, noting to our listeners that we're going to discuss nutrition and movement in these years in another podcast. So we're going to focus on some of those other aspects. But a really important early aspect, and one aspect that can bring families together or children together, is play. How can healthcare providers educate parents or caregivers on the crucial role of play in fostering a child's cognitive and social and emotional development? Jennifer, should we start with you?
Yeah. There's a saying, play is the work of childhood. And if we think about what we now expect our children to do, to attend multiple structured activities, jump in the car so that mum and dad can get to work on time, go to after school care, we need to make time for children to have explorative play, to figure out what things do, how things work, but also to figure out how to interact with one another. Many of us are going to work in teams as adults, so childhood is the perfect place for us to practice waiting, taking turns, building, breaking, managing distress, coping when things don't go as expected, and all of these things can be done through play. There's increasing pushes by moving prep into the education system to do tasks at desks with pens and paper, but we can learn about place order by racing a car down a ramp. We can learn about numbers by having a pretend shop. We can learn about the careers we might have by pretend play, such as playing doctors and nurses. And all of these things are things that we can do as parents, as extended family, and also in that daycare setting.
I'll just add to that, I think allowing children the opportunity to be bored fosters curiosity and exploration of the world around them, and outside playing in the mud or picking at leaves, looking at flowers. When they've always got an organised activity or heavily scheduled timetable or a screen in front of them, they're missing out on that opportunity to develop their curiosity.
And they're also missing out on an opportunity to move. Because we know that when we move in play, we eat better, our behaviour is better, we sleep better. Yeah,
there's so many important elements there. It's funny how play seems to be the centre ground for so many other, as you said, there's movement, there's sleep, there's, it'll encourage sleep, there's often food is a component of it, there's clearly social connection, interaction is a big part of it, and nature time, which we're identifying as just so important, as opposed to this culture of the busyness of life that is infiltrating childhood's lives as well as adults. But allowing the creativity and the story to come back into a child's relationship, very important. You mentioned before how critically important social relationships are for a child's development and for their sort of forward prognosis, as it were. So can we sort of comfortably say play is a key part of that social relationship aspect as well?
Absolutely. And we don't learn just from our parents, we learn from our peers. So when we watch how another child copes and manages with distress, or we have another trusted adult show us a way to do simple things like taking a big breath or using redirect and distract, we can actually learn a lot through just play.
So we've danced around a few different topics, sedentary behaviour being a big one, and perhaps one of the most contemporary relevant issues we face is device and screens that have sort of infiltrated, to say it politely, our life. So what are the recommendations around the current guidelines around physical activity, behaviour, but also screens and devices for infants and toddlers? And do we have any data on trends to date?
In America, some recent data has shown that the recommendation is no screen time under 2, but in most children under 2, they're having 2 hours a day. Yeah?
I'm not surprised by that at all. I think that our national guidelines would recommend no screen time at all for children under 2 and no more than 1 hour of screen time for children aged 2 to 5. But I guess the caveat to that screen time is it should be reasonable content screen time, and ideally parents are engaging or adults are engaging with children while they are consuming that screen time. And in terms of the activity guidelines, there's a recommendation for 3 hours a day of physical activity spread throughout the day. And in older children, that includes an hour of energetic play, so running, kicking, heart rate up kind of activities every day. And interestingly, the guidelines also talk about restraint, so having a child in a pram or a car seat or a high chair. And the recommendation is that there's no more than 1 hour of continuous restraint at any point for children between 1 and 5. And I think, again, there's a lot of kids in cars, in prams a lot of the time due to the busy nature of family lives. So I think parents on the whole are not aware of those guidelines. I wasn't aware of those guidelines when I was parenting my children early on. So I think there's a role to definitely increase awareness of what those recommendations are.
It's a very big topic because it would seem to me a sort of larger cultural phenomena that over the last 70, 80 years there's been this sort of nuclear family idea and a slight disintegration of so the parents have to manage their children a little bit more lonely than they may have, say, 80, 90 years ago when they may have been aunts, uncles, grandparents more closely in the house. And so it seems to me screens are sometimes used as a kind of third parent in a way. You know, I've got a dad or mum's got to go do the washing up, I've got to hang up the clothes and do all these sort of things.
Home.
We've got to work from home. All these really just day-to-day things, and there are no other adults nearby. The TV becomes a safe, inverted commas, way just to pin them down for a bit of time. So there's some real practical challenges to this that are not really based around whether you're a good parent or a bad parent or any of those sort of hardcore terms, but just the reality of life. So what are some strategies that parents can incorporate to support them and to help them through these challenges around device use?
I really think it starts with being mindful of your own device use as a parent. We're all probably guilty of using too much screen time and too much device time, but having awareness around your own use and how that might impact on your interaction with your children. When your face is in a screen, you're not interacting with your children. And also you're not role modelling appropriate device use. So I think it starts with being mindful of the place and the positive times when we can use screens, but also when maybe it's too much. And I think using screens as a babysitter, obviously it's very effective, but similarly using screens as a distractor when children are uncomfortable, unhappy. I see it frequently in my consult room that child is unhappy. The first go-to strategy to try to relieve distress in that child is to distract with a screen. And I think that comes back to not giving the child the opportunity to self-regulate or the parents to help the child learn to self-regulate without the use of an electronic device. So it's an easy solution, but in terms of long-term opportunity, I feel there's a significant cost there. I often talk to families about starting as you mean to go on with screen time as well. I have teenage children, and so device use is a big thing within our house, and I think we've got some family structure and rules around that, which I'm happy were in place when they were younger because we can fall back on those a little bit now. But things like specific times for device use, no screens at the table when we're having a meal together, tech-free family time if everyone's together, not making sure that there's no devices. So I think awareness around the role of devices, parents' own use of devices and boundaries is really, really important.
Yeah. And we also know that media use really affects how well a child sleeps. And so suggesting that parents avoid screen time in that 30 minutes before bed and making sure that bedrooms are screen-free zones are really important recommendations too.
Absolutely, yeah.
There's some really great points there. So role modelling is a big one because we should demonstrate that we can actually make this change before expecting a 4-year-old to make it. I think is a reasonable expectation. And what are their reasons for use? As you say, is this something that is just a bit of switch off time, or is this actually being used to manage distress, which really we need to learn how to manage in other ways? Structure around that, whether it be no screens before bed, for example, or at the dinner table, or dare I say in the toilet. And the shared experiences you said as well there. And there are options for that, whether it's a documentary or an interactive sort of screen or maybe a school lesson. But there are some fun things you can bring into that element as well. So why are we worried about screens, Jennifer? Like what's the impact of screens? What's the thing that we're actually worried it's going to do or is doing? Do we know?
We have all had screens growing up, haven't we? We all watched Play School. We all probably watched Play School while Mum was getting dinner ready. And so I think screens have had a role in our lives for a very long time. What it does is it steals from the opportunity to grow the developing brain with relationships. So children don't learn language from what they hear on a screen. They learn language from the person that talks to them. They don't learn how to problem solve. They don't learn how to plan. They don't learn how to manage their distress. All of those things depend on the relationships with their trusted others. And so the thing that screens do is it steals from that opportunity to grow and develop the brain.
So there's a real opportunity cost there.
Opportunity cost.
Yeah.
Excellent.
And obviously the role modelling as well. Is there much evidence around the inattention concern? Those sorts of things that can maybe encourage a shorter attention span of those things. Do we have any evidence around that?
There is no evidence.
Oh, well, that's reassuring. Is that absence of evidence or evidence of absence?
I think it's absence of evidence.
Okay,
so we don't
right.
know
So
what the
we'll wait.
long-term effect of those short, sharp interactions with the screen are.
Okay, so not reassuring. We just need to know. We just need to find out. And we've talked about sleep, clearly relevant to assessment, clearly relevant to everyone in the family and relevant to screens. But what are some common sleep challenges faced by toddlers and young children? And what's the guidance around establishing a healthy sleep routine and being able to identify and address sleep disturbances?
Sleep's really important because without sleep, children can't play. They often don't interact well with their parents and they find it very difficult to concentrate and attend. So most children probably don't get enough sleep. We want our toddlers to have between 11 and 13 hours a day with 1 or 2 naps. And we want our preschoolers to have 10 to 12 hours of sleep a day with 1 nap. Most children still have an opportunity to have a wind down in a traditional way. They might have dinner, bath, story, bedtime. But other children, that doesn't work in the family, particularly when a parent's still working into the evening. So something that I like to recommend is just, what does it look like when you go camping? What happens? Well, the lights go down, it gets quieter, the TV's not on, the podcast's not on. And so really trying to replicate in the home that opportunity for the child. And it might be something as simple as doing a puzzle or playing Lego in their room for the 30 minutes before bed so that they have an opportunity for the natural secretion of melatonin rather than the increasing trend that we're seeing for neurodevelopmentally normal children to be given melatonin to promote sleep initiation. I think Nicole touched on the other thing, that initiation is one part of sleep, but nighttime waking and sleep associations is another thing that really challenges parents. And so being careful about how many sleep associations we introduce is important. Examples of this might be white noise. It might be blue light or no blue light. It might be dark curtains. It might be a certain sleep sack. And each of these things are used by children to help them resettle when they come into light sleep at night. And so you need to be careful about how you get a child to sleep at the start of the night. So overnight, they don't ask for that help again. And I think you mentioned perhaps feeding to sleep and the importance of not using a bottle to resettle overnight beyond the first year of life.
I often talk to parents, I give the analogy of their own sleep patterns. And as adults, if we sleep in a hotel or away from our usual sleep location, it's harder to sleep often because we have our own sleep habits. And so when we are set in those ways, it's very hard to sleep without them. And so I try to give the parents the example of setting up those habits for their child and then needing to replicate those exact habits frequently for the child every time they wake. So like you said, Jennifer, the fewer of those ingrained habits that the children have, the better. But it's very hard for parents to undo that. They have to spend the time required to teach their children a different way to sleep or to sleep without those habits. And that's often very challenging, isn't it? Because the parents have to get up and go to work the next morning. They might live in an apartment where they don't want to keep the neighbours awake in the next door unit. There's lots of reasons why it's very hard, particularly in the early hours of the morning, to not use those habits and those sleep associations to get your child back to sleep.
So what do we do then? So in the sense that we talked about the importance of having sleep routines towards the end of bed to sort of signal to the brain, to the child that sleep is impending and giving them time to as you said, sort of spontaneous time, or as a free time, as it were, to transition themselves and prepare themselves for sleep. But we've got to be careful of the sort of condition response aspects, aka the sort of various stimulators, whether it's a sleep bag or a bottle. They may learn that I can't sleep until I've had that. So we want to provide the environment for sleep without too many really specific or anchored cues.
I think the cues and the routine and the consistency are important in that lead up to sleep. So that predictability of bedtime, bath time, book, bed is really, really important. So I think that is part of the sleep habit, I guess, but it's the use of additional sleep aids, I think, and feeding to sleep or relying on white noise, or even in babies, those rocking devices that have to be replicated. I think that's where we can educate parents. And I often talk to parents about responsive settling and teaching their child how to sleep without those things, which is hard. It means settling your child, putting them back into their sleep space, telling them you love them and off to bed, and then 30 seconds later doing the same thing again because they've stood up and they're distressed. But sticking with that, and over time, and time is sometimes days, it's not weeks or months, that those habits can start to become less sticky and become easier to overcome.
Yeah, I think trusting our children that they can get themselves back to sleep and not over-responding when we hear our children fuss is good. The Ellen Barron Family Centre has put together a beautiful set of videos on their website on responsive settling, and parents often find it really helpful to watch another parent using those skills.
Are there any other signs or symptoms that we should be aware of that sleep may be an important factor here?
We probably want to communicate with our parents that it's quite normal to snore in childhood, and that's because the adenoids and tonsils get larger between the first year of life and the fourth year of life, and then start to actually go away and regress. And so in that time when the tonsils and adenoids are large, a child may be a noisy breather in sleep. They may snore, but they may also have pauses in their breathing or periods where they come alert and awake because they've had obstructed breathing. And the last thing is probably the thing that you would see your GP about is if you went from snoring to periods of apnea to periods of obstruction, because that's when we would need some further investigation and support.
Yes, I'd agree with that, Jennifer. And those are the children that would be referred for sleep study or straight to ENT review.
Yeah, excellent. So therein lies the sort of art and science of medicine, isn't it? Because as you said, the tonsils and adenoids may be enlarged. Some degree of mild obstructive breathing or a bit of snoring may just be physiological and normal. We don't want to pathologize that. But if there are daytime symptoms, fatigue, behavioral concerns, other aspects that are worrying, and we go back and look at the sleep and we see that snoring is a dominant factor, and we look in the mouth and see some big tonsils there, maybe we need to look a little bit further and down that line, whether it is, as you say, ENT or sleep study or something like that. So moving on from development and determinants, I'm just going to zoom out a little bit from the child specifically and talk about their social and emotional environment, which we've touched on a bit, but it definitely deserves to be touched on a lot more because obviously these are the very clear role models and people in this person's life. So being a parent in Australia, which we've again touched on, can be very demanding. It's also very rewarding, but it can be very isolating as well. So what aspects of a parent or family's community or environment do you feel are integral to raising mentally and physically healthy children?
The most important thing is probably the wellness of the parent. And so part of every well child check should include checking in with the parents on how they think they're going. Something as simple as turning to the parent and saying, "And how are you?" after you've talked about the child's concerns is a great way to start. The next question to think about is, what are their indirect supports? You know, have they moved to an area where they don't have aunties, uncles, brothers, sisters? And so exploring who they can ask for social help or emotional help is another important layer. And then recognizing that there are many universal programs available in every community where we can connect with other adults experiencing the transition to parenting, because it's not easy. And what we're asking in the toddler years is not only transition to parenting, but we're asking for parents to balance between work and parenting. So I think some examples of local resources to build community might be a soft entry, such as a baby massage group or sensory play, where they can meet other mothers living in their community. It might be a pram walk with the city council. It might be baby rhyme time at the local library. All of those are ways that we don't medicalise parenting. We make parenting very natural and give mothers and fathers opportunities to connect with other people who are in the same stage of life. And then at a higher level, if parents become worried and feel that they need more support than their trusted other, just really normalising that through childhood, we all have questions. And there are places that you can ask, like community child health, family hubs, the general practitioner, always. And then if you have developmental concerns, you can enter a door such as the Child Development Service.
It takes a village, doesn't it? And I think part of our role of healthcare professionals is sometimes helping people build that village. You know, they might not come with a village, so
and
we can help them build it.
Find the right door to go in and then supporting their engagement. And so one way to support the engagement is to choose an organisation that the family already knows and trusts and do a warm handover to that service.
Don't go anywhere. Our conversation continues after these messages.
A Better Choice food and drink supply strategy for sport and recreation supports clubs and facilities to make healthy options easy. Healthy food makes us feel great. When we put the right fuel into our bodies, it helps us stay active for longer, improves focus and concentration, and boosts our ability to perform. Sporting club and recreation associations can now access resources and support from Health and Wellbeing Queensland to make the change to healthier options. Find out more by searching A Better Choice at hw.qld.gov.au.
And now, back to the conversation. Nicole, this is a nuanced and slightly difficult question for you, but it's a classic GP question, because how do we delicately and respectfully raise the possibility and even the probability that the behaviours and the role of the parents are having a major impact on the child's behaviour? And as I say, probable or possible. You know, we talked about screens being an example of that. Most lifestyle determinants can be an example of that, or the way one responds to distress or those sorts of things. So, you know, therein lies a potential source of conflict. So how do we manage that to get a good outcome from that?
I think that's very tricky. You've got to start by understanding what the family situation and the family dynamic is, and sometimes asking parents about what their own experiences of childhood were like, and what were they like as kids? What do their parents tell them about their own personality traits and strengths and weaknesses when they were children? And sometimes even having that conversation will allow parents to reflect a little bit and say, actually, I was a lot like this, or I see these traits in myself. And I think just having some open conversation about modelling and children learning about emotional responses to things and how it comes back to all the things that Jennifer mentioned earlier about learning about how to interact with other people and how to communicate and how to respond to different emotions comes from those opportunities. And so we just need to gently highlight to parents that children are learning from what they're seeing and from what they're experiencing. And perhaps some of the behaviours and responses are related to stresses within the home environment or things that might be challenging. We obviously have to be very careful in raising those conversations in a non-judgmental, non-accusatory way, but more in an empathetic way. I can see that things are really hard for you. You're trying to work. You've got 3 kids you're trying to juggle. Your partner's working away. You're a bit stretched for money. Things must be really, really hard. And I think giving parents permission to be kind to themselves, that you can't get this right all the time, but sometimes it is going to be hard and sometimes you can't do your best, but you're trying to do your best, and acknowledge that and acknowledge the positive things that they're doing.
I think asking parents what the hardest time of their day is often very enlightening. It tells you where they're really struggling, and it often also opens up an opportunity to talk about times where they don't parent in the way they wanted to parent, particularly if there's early childhood adversity and their own experience of being parented wasn't positive.
That's excellent. So coming back to those core tenets of curiosity, you know, it never hurts, just ask more questions and find out more information. And often, as you say, with those sorts of open-ended questions, the answers somewhat unfold organically often, which is why we start with open-ended questions. Compassion being at a base of it, which I think comes quite naturally, hopefully, to most health professionals, but always good to remember. And learning and addressing what can be addressed. And the hardest part of the day is a very good sort of question to ask, or it's a sort of semi-open question, and it will give a lot of information. We talked right at the beginning around the comprehensive child health check and asking what's going well. Is this a time that you can sort of bring in some of those things as well?
Yeah. So our most judging person in our lives is ourselves. And when we're a parent, we are very critical of ourselves, aren't we? And
yes.
so
and there's lots of opportunity to compare to other parents too, isn't there, with social
and
media.
And that might be
mothers.
helpful or harmful.
Mm-hmm.
Yeah. And so highlighting for parents that they're doing a good job, they're doing their best. Look at this beautifully presented child. Look how well she's behaved. Look at her beautiful eye contact. Look at that lovely, clear speech, is sometimes a way of gently reflecting the effort that they're making as parents.
I think you can take a strengths and difficulties approach similar to how we do when we're assessing children is, I can see that you're doing a lot of things really well, and there's some things here that are challenging. Let's have a look at the things you're doing well, and then let's think about how we can help with the things that are really hard.
Yeah, it helps to see the whole person, doesn't it? Because people feel less judged because of that. They understand the balance, they understand the context and the nuance you're trying to apply. Zooming out a little bit more now, so from the family now looking at the sort of wider home environment, what are essential safety precautions that parents and caregivers need to be aware of when creating that safe environment for infants? And as you said, they go through that period from 12 months to 4 years where they are not doing much to absolutely everywhere. So there's some pretty important aspects there.
I always think about 3 main safety issues in the toddler and preschool age, and that is heat, water, and falls. When families are choosing equipment and furniture, they should really look that they meet Australian standards. And the 3 most important safety things are perhaps your car seat with a 5-point harness, a pram with a brake, and a safe place to sleep. And that's probably all a child needs. When they're young, parental supervision is the best way to keep children safe and to be beside them as they explore and play. We all remember that time where every single book was pulled off the shelf or every single saucepan was pulled out of the cupboard. Parental supervision is the way to keep safe at that time. But as children get older, we need to help them learn and teach them explicitly what is safe and unsafe. We have had some ongoing drownings in Queensland this year and near drownings. And so just over the summertime, it would be really good if we could remember that toddlers and preschoolers should be at arm's length in the bath, in the pool, and in the ocean. The other thing that comes up with home safety, because you spoke specifically about that, is the reminder that poisonings, overdoses, are also common in this age group, and that those things should be kept in a high cupboard and ideally locked.
And that could be supplements, medications, almost anything.
Absolutely.
Yeah.
Just one other thing that comes to mind, Jennifer, is hot liquids as well, the hot cups of tea and coffee on the bench that little hands can reach up to, causing quite significant harm as well.
Yeah, it pays to just consider what can little hands do in this situation. When you're cooking something on the stove and the handle of that hot boiling water is over the tip, I'll just turn that slightly to the back. just add those little thoughts. Now, this has been a great conversation, and thank you both for your time. We've touched on a few really great resources, but are there any other really practical tools or resources to help parents navigate this period of their life, or with their parenting, for example, if they do want to reflect and add to that, or early intervention programs and social services?
I would always start with the Red Book as a reference. Not only does it look at our child's growth and development, but it holds all that information together. The other thing that we recommend is the Raising Children's Network. So this is a very well curated website based down at the Royal Children's Hospital in Melbourne and the Research Institute there. The information there is evidence-based, it's updated regularly, and is a great source of truth for parents. We know that relational health is the best way to grow little brains, and so probably the most important parenting program would be Circle of Security, which looks at the relationship between the parent and child and how we develop a strong bond and attachment. Local community centres also have universal parenting programs that really help, because sometimes parents weren't parented in the same way and need a universal language to speak as they parent their kids. An example of that might be 123 Magic, or it might be the Triple P program.
And Nicole, what about families who come from First Nation backgrounds or culturally diverse communities? How can we improve the delivery of healthcare engagement with these families from a resource point of view and an assessment point of view?
I think we're very lucky within our communities. There's such a rich diversity of different cultures. And obviously as healthcare professionals, we can't understand them all or have a sense of knowledge. But it's a great opportunity to be curious with families and understand what their value systems are and what their beliefs are and how that plays into their parenting and their health choices for their children. Again, I try to ask lots of hopefully respectful questions to understand families and then adopt my advice or my approach to hopefully match with that. It's about knowing your community as a healthcare professional and then knowing what resources are out there and what opportunities you have specifically in your area to refer people to.
There's an element there that requires some proactive nature on the behalf of the health professional then, because it's not like when you started a practice, you're given a book on all the resources that exist in your community. That's something that you've got to go and find out. And sometimes, as you say, the library or the council may have certain things. They're a good place to start. But there's usually all kinds of hidden gems in communities that I know at our clinic, we pay a nurse once every 6 months to go out and just explore and find out and update us all as to what, create a little book and come back to us. So, there are ways that we can really engage with our community in a sincere way. To wrap up, and thank you both for your time and expertise, what are top 3 things you wish every family knew about the toddler's years and health? Jennifer, let's start with you.
This is the most precious time in our life. Toddler time really does matter. It is when our children learn to communicate their wants and needs so that they don't have to use their behaviour to tell us how they are feeling. It's when they check regularly if the world is safe and predictable by asking us to provide structure and boundaries as they grow. And it is when they watch our behaviour, modelling how we look after ourselves and how we treat others.
Great. Thank you. Nicole?
Well said, Jennifer. Mine are a little more specific, I suppose, the top 3 things that I wish parents knew. But number 1 is, and we've touched on it in a few points in this conversation, but toddlers don't need bottles of formula. And the formula companies are very good at marketing that they do. But children who have a well-balanced diet, who are healthy children as a general rule, do not need to be having bottles of formula beyond 12 to 18 months. And this is a really common conversation that I have with parents. My second point we've also touched on is that toddlers don't need to rely on screens to help them self-regulate their emotions. And that flows into my third point, which is that young children need to experience the range of human emotions that we all experience: sadness, happiness, frustration, anger. And they need to learn those and how to manage them and build their toolkit of what responses they're going to use and how they're going to feel okay in those moments of discomfort. And as parents and caregivers and health professionals, our role is to model those behaviours, to coach them through those behaviours, and to provide them with the opportunities to experience the emotions, to learn the appropriate responses.
Excellent. Well, hopefully this podcast helps professionals and parents very much in that respect, and the resources we've mentioned I'm sure will. So thank you both for your time today. It was very useful.
Thank you for the opportunity, Sam.
Thank you, Sam. Thanks, Jennifer.
Today we've been talking to Dr. Jennifer Deacon and Dr. Nicole White on health and the toddler years. For more information on today's topics, visit the Health and Wellbeing Queensland website at www.hw.qld.gov.au. If you've liked today's conversation, be sure to subscribe for future episode updates. We'll see you next time on the Clinician's Guide to the First 2000 Days.